Welcome everybody. It's great to see so many people here. So we're going to talk about something a little bit different today. This is a non-promotional symposium, and we're going to focus on active monitoring, and this reflects collaboration between healthcare professionals, both medical and nursing, as well as WMUK, which are the Waldenstrom's patients advocacy group here in the UK, and also BeiGene, who've kindly supported these initiatives. So there have been a number of initiatives around this, and we'll hopefully be able to highlight some of those and allows for some discussion. So the purpose of this meeting is to look at aspects of active monitoring and from the perspective of WM patients, but this is clearly applicable in other areas, and how this impacts HCPs as well as patients, to go through a UK-wide consensus study led by Dave, who will take you through the results, and how we share and disseminate this information and promote best practice in this area. So this is our agenda today, and I won't dwell too much upon that. And this is our faculty, so you can match people up to the mugshots here. So I'm the old guy on the left. We've got Jane Nicholson, who's the CEO of WMUK, our colleague Alison, who's the Chief Nursing Officer of WMUK, Dave Tucker, many of you will know, is consultant haematologist from Truro in Cornwall, and Charlotte Bloodworth from Cardiff. So these are our various honoraria. So our first question, we've got responses already, excellent. So if we can, people can add in, I think the system will allow you to add up to 5 words, so please enter as many as you can. In one word, how do patients react when they are told they will go into watch and wait? And terrible term, as we all know. It's clear that anxiety and confusion are the dominant features at the moment. Worry, confusion, questions. So clearly a time of significant uncertainty for patients. Okay, so I think we shall just maybe leave that for another 15 seconds or so. So it's clearly that the dominant themes are certainly coming out, and certainly in terms of anxiety, confusion, uncertainty, and these are all the dominant things that are coming through. So we're now going to show a short video, and this is a video of a patient, and this is Andrea, and she will be discussing her own experience and insights into active monitoring.
I had mixed emotions because I was like, oh, thank goodness I haven't got to have a chemotherapy or any other treatment at that time. But then on the other hand, you're just thinking, is the cancer going to get worse? And when would I need treatment, or would it be too late? Because I think you think of cancer as being a solid tumour, whereas blood cancer is very different, and it's treated very differently. So yeah, because usually you think, oh, just cut it out and I'll have treatment and everything will be fine. Whereas with WM, you're living with cancer, it's not going to go away. So it's understanding that, really. When you know an appointment's coming up about a week before, you start to get apprehensive and a bit anxious, because you're always thinking, well, maybe this time they're going to say that the bloods are showing that WM is sort of coming back with gusto and that you might need treatment. So you do worry. And on that day, when you're, when I talk to him, you get quite tired really by the end of that day, because you're so anxious about it and you want things to go well. But by the time you've had that conversation, it's like, oh, thank God, that you're okay. It's that relief, really. But it's that build up is quite difficult. Over time, because I have made use of WMUK, my knowledge has improved, and talking to different people with WM also has made a difference. So actually the questions I'm asking are more informed. So it is a different process in that way, because initially you're just like, a rabbit in headlights, really. You don't know quite what to ask or how to ask it. But over time, it has got easier. I still prepare. I still have questions. I write everything down. And and as he's talking to me, I'll write little notes as well so that I can look back and look, and see later on. And when I'm talking to other people, I know what I can refer to. I just think you feel, because you have greater knowledge, you feel in greater control when you're having that active monitoring. That would be to be really active in their listening. I think that's key. To really listen to their patients, and what is it that's troubling them. Because sometimes the questions you ask, it might be other things that are underlying that. So it's really getting to the bottom of those symptoms that a patient may have.
So we're very grateful to Andrea, who gave her time for the filming of that. She did come all the way up to Leeds to get that filmed. And what we didn't see in that video was what a skilled interviewer Alison was. So we had to cut her out for reasons of brevity for the video. But she was able to guide the discussions in a way that generated a really insightful video here. And obviously the key for us as clinicians is to be using ears and not our mouth, really. So, further Menti question, again, if you've forgotten the code, it's up there at the top. And it's in this one, in your outpatient practice, how often do consultations involve discussions around active monitoring? And that is, there we go. So I think the thing about this is it's clearly demonstrating that this is a sort of major part of our role as clinicians, is talking patients through the uncertainty of conservative management approach and deferring treatment. So with that in mind, I think we'll go to our panel discussion. I'm going to go to Jane first, as CEO of WMUK. We've discussed before how big a proportion of your work and efforts are around patients who've been told that they're on watch and wait, which obviously is a terrible term. But you kind of give your insights into the impact of this on you as an organisation.
Yeah, sure. Hi, everyone. The biggest cohort of patients that engage with WMUK are those on active monitoring, and I think it's probably self-explanatory, really. For a lot of them, they're given a diagnosis of an incurable cancer, but they don't feel they're being treated. And it's the mental burden, I think, that goes with that. And some people have a really good experience of being placed on active monitoring, and some people will just leave that session really just with that as a takeaway. Hold on, I have incurable cancer, but I'm not being treated. So we're a small organisation. We always want to look at where we can have the most impact. And we thought, really doing something for patients that are on active monitoring was important. Right when I joined WMUK 3 years ago, one of the first things I constantly got told by patients was, can we please not call it watch and wait, because it's like watch and worry, or it's like watch and wait to die. It feels like I'm just waiting for some impending doom to happen. So their preferred term was active monitoring, which you obviously can see has, gone into this piece of work. And for us, as an organisation, we have the only WM support line that has grown massively over the last 12 months, the demand for it. And I think, again, that goes with the mental challenges and burden that comes of being on active monitoring. Patients will think, is this rash something? Is this pain I've got something? Is this something to tell my consultant about? Do I now need to be on treatment? Is my cancer advancing? We're all human beings, right? And for someone to tell you have an incurable cancer and for you to get your head around that and your loved ones and your family, but then explain that you're just being checked on almost every sort of 3 months, is quite a lot to figure out and live with day to day. So we wanted to do this piece of work to enable better conversations to happen between patients and their healthcare professionals, because everything is a partnership, right? And we're just about, I think, empowering patients and informing them. And as Andrea said in her video, giving them the confidence to have these conversations, because not everyone feels confident to have a conversation with the healthcare professional, and to have a framework that it was structured around that patient and doctor could use together. So by the time you left that appointment or a follow-up appointment, both you and your loved ones understood what was happening to you, why it was happening, discussing all the relevant bits, and you could leave that appointment feeling in control of what was going on.
Yeah, thank you. I'd just like to kind of reiterate, and Dave will probably maybe chip in here, as it's probably the commonest reason I get referred patients for a second opinion. I very rarely get referrals for second opinion, and people are on active treatment, because that doesn't seem to precipitate that. But people who've not had that sort of conversation are often left looking for alternatives. So, Dave, what's the most challenging aspects for you in the context of these sorts of consultations?
Yeah, well, I would say, in my experience, it is variable. It does depend on the individual, but you're doing a number of things when you first meet and make a diagnosis of Waldenstrom's. You have to develop a relationship of trust with that patient, because they're going to be with you for a long time, hopefully, and you're going on a sort of to use a parlance, a journey with them, and it is about developing a relationship. That doesn't happen straight away, and it usually develops over a number of consultations. So that's the challenge of kind of developing that trust with them. Another challenge, I think, which is quite, when it's done well, it's really rewarding, is trying to explain the technicalities of what you're doing in terms of monitoring a patient, and the things that you're looking at, the way that that Waldenstrom's behave, the biochemical parameters that you're monitoring, and you sort of want to empower the patient to make them an expert as soon as possible in their own disease. And often patients are very, very expert, and they do monitor and track their various parameters. But kind of spending time explaining that to patients, that is a significant challenge. If it's done well, it's really rewarding. If it's not done well, you may well lose the trust of the patient, as you've said.
Yeah, thanks, Dave. I'd like to turn to Alison now. You probably speak to more WM patients than anybody. So what are these patients phoning you up about? What are they asking you?
Yeah, so basically I run the only support line for WM patients. And sort of what Jane alluded to, the majority of patients that phone me, it's not the people who are on treatment, the people, who are quite well supported, it's people who are on active monitoring. And they phone up, and they've had a consultation, there's some really heavy words used, you've got an incurable cancer, we're not going to treat it, and then, we're not going to speak about this for another 3 months. And a lot of it is they've gone home in an absolute tailspin. What are they meant to do now? What resources are out there? Because a lot of people say, I was told I've got this cancer, go home. I don't know who the name of my nurse specialist is. Have I got a nurse specialist? Who do I speak to if I've got any concerns? They're not given any literature, let alone about active monitoring about their cancer. And, it's just that thing of they're not signposted to any support. They feel really like they've had a bombshell dropped on them, and then they don't quite know where to turn. I think as well, the biggest thing is, they have their follow-up every 3 months, but around that 3 months, the biggest thing that comes out is, you try and live you try and live with this disease, you try and carry on with your life. But, you know, as you're coming up to those blood tests and that review, everything starts going through your mind, your family, your loved ones. What happens if it's bad news? What happens if everything's changed? And they've got to almost prepare themselves. They've got to really sort of build themselves up for that and then walk away from it again. And they say it's that complete psychological turmoil every 3 months that, you know, they have absolutely no psychological support from their clinical team. You know, some people are very lucky that they do, but that's why a lot of people contact the support line, because they say, I just want to speak to somebody else. I want to speak to somebody who even knows what the cancer's called, what it's about, and actually what this actually entails. So I think that's it's definitely the psychological burden that active monitoring brings is why they sort of phone, I'd say.
Yeah, thank you. So I'm going to go to Charlotte now. So we've undergone a rebranding process and we've got active monitoring. We want to promote this as a positive intervention and active intervention. How do you approach the sort of active bit of active monitoring with your patients?
Very difficultly. I think it's such a grey area, active monitoring, and it's so different for everybody. As a specialist nurse, it's so much easier to sit and explain what a treatment is. You know how long it's going to last. You know what it's going to entail. But active monitoring really is so grey, and it is wound up with a lot of anxiety as well. So I think on those first few appointments, it's a lot to ask somebody to take it all in, to really understand. It's good to have somebody with them so that they don't go back and get those questions of saying, why aren't they treating you? You know, we've had people come to us, you know, before saying, oh, my friend says, that's it, you're not doing anything for me, there's nothing for me, I'm going to die. And it's, you know, completely the opposite. You know, we don't need to do anything, we've got plenty there. So I think on those first initial appointments, I probably think of it a bit like dementia care, because I think after being bombarded by the doctors about, you know, what they've got cancer, this is what it is, it's really rare, to get your head around that and then come through to me for a big ream of information about what you need to do on active monitoring is really difficult. So I think, first of all, the most important things that I try and do in those initial appointments is give them a feeling of reassurance. So it's not so much the words, but it's just leaving them with that, you know, we're here if you need us, I'm not worried, so you shouldn't be worried, that type of thing.
And I'm assuming you're also then fielding quite a lot of calls and that are follows on from that the likes of Dave and I don't really see.
Absolutely.
I guess that's a big thing for you. Yeah,
definitely. So I'd probably say I've been a specialist nurse for 15 years, and I'm not surprised anymore by the questions that I get, the phone calls that I get. But yeah, everybody is very different. Like Dr. Tucker just said, everybody sort of leads their own consultation. They've got their own worries. We get a lot about sort of infections. I think that's the legacy of COVID as well. Still get people sort of turning up to clinic with sort of visors on and, you know, the full sort of protection. A lot of questions about treatments when they're nowhere even near treatment, but people still like to talk about it. So the challenge for me really is to sort of bring it back to that active bit. What can people actually do now to help themselves? And a lot of that is sort of health promotion and looking after themselves.
And Dave, what do you think, looking back on your career, that you've had adequate sort of instruction, training, teaching on this?
Well, not really. No, I mean, I think it's very much lumped together with all the sort of low grade lymphomas and sort of active monitoring and what was watch and wait was something that you kind of learn on the job, and you don't really, in my experience anyway, you don't really get a lot of structured teaching or training on it. So no, I wouldn't say. And I think as a result of that, I was just going to add, for the doctor, especially for the inexperienced doctor with looking after Waldenstrom's, or the may not have very many cases, it's actually quite a sort of uncertain, stressful experience as well, looking after active monitoring, because you don't always know when the right time is to start treatment. It is a grey area. It can be, it's often, not it's a decision that you have to make together with your patient. So you will often say, have a look at the results, and then call the patient in, and you'll be thinking, I wonder how this is going to go, because you're not entirely clear yourself, and often you are led by how the patient feels. And I often tell patients, you'll probably be the one to tell me when treatment is needed, and that's sometimes helpful for them to realise that there isn't something sort of secretive or in the background that they're not aware of. Often it's very much a symptom-led disease a lot of the time. Not always, but most of the time, I would say, yeah.
Okay, thank you. I think we've covered lots of aspects there, and I think we're just about on time, so we're going to move on. And I'm going to pass over to Dave, who's going to take us through the UK-wide survey that he and colleagues have done and the results.
Thank you, Roger. And I'll try and keep you awake. I know you just had your lunch, so I'll try and keep you going for this next session. So, in sort of response to some of the feedback that Waldenstrom's UK were getting about sort of variation in patient experience of what active monitoring is and how it's communicated and how it's done, we have developed a UK-wide consensus on developing some what we thought were sort of standards of care for active monitoring in Waldenstrom's. Now, this is work in progress. It's not yet published. It's subject to some further research, but we're hoping to get this out, and also it's fed into a resource which hopefully is going to be useful for you as a sort of a patient tool for active monitoring. So what do we do? So what we did was we got together a lead of experts, I suppose, in Waldenstrom's management from across the UK. We had interest from a number of. Ultimately, what we did was we took consensus and we took opinion from a number of healthcare professionals with interest and expertise in Waldenstrom's, and also nearly 200 patients living with Waldenstrom's, to sort of draft a form of kind of a structure for active monitoring. And it was facilitated by an independent specialist healthcare and supported by BeiGene. So thank you to them. So how do we do it? We used a modified Delphi approach where we had a steering group of 8 people who agreed 6 main topics to focus on around active monitoring. And those people are listed over here on the right-hand side. Some of them are here today, obviously, as well, which is good. And then within those 6 topics, we developed statements of consensus, sort of markers, or sort of, this is what we think is the sort of minimum standard. And then we sent that away to a group of peers and a group of patients, around 200 patients, to see if they agreed with us. And then that came back to us and formulated the form at the basis of a manuscript, which is still undergoing some changes, but it is something that we hope to publish. So the areas that we looked at were, we had 40 statements, quite a large piece of work really, in determining and defining what active monitoring was for patients, what the minimum standards would be, how it would be communicated to patients and to healthcare professionals, how holistic care, things like physiotherapy, dietitian, counsellors, sort of psychotherapy might influence active monitoring, might be part of best practice, and then how that might be using tools developed with charity and industry that we might improve education for doctors and healthcare professionals in looking after patients. So we had an overwhelming response, 230 responses. As you can see in the pie chart on the left-hand side, a lot of those were from nurse specialists, but in the pie chart is the healthcare professionals, so nurse specialists, consultants, other members of the team, the multidisciplinary team, some registrars, and then below that were nearly 200 patient responses. And I'm pleased to say that, perhaps not unexpectedly, the standards that we developed were unanimously agreed as a good standard of care, and that was because they were drafted by people with getting feedback from patients, really. This is just a sort of a graphic to show that we had a 75% threshold for each of these statements that we wanted agreement on, and we got agreement unanimously across the board on what we should do. And I'm just going to briefly explain the recommendations that we put forward. And the first one, and what you've already heard, is that active monitoring is the preferred term for this period of time in the patient's journey when they're diagnosed but yet to be treated, or after treatment, between treatments, so it's a period of active monitoring. Secondly, that within those periods of time that patients obviously should be offered face-to-face as well as virtual consultations, and should be able to access that in between consultations if they need to do so. Thirdly, we spent quite a lot of time defining and emphasising the role of the clinical nurse specialist, because that's absolutely crucial in that link with the patient in terms of active monitoring. And then the next one was about supporting the patients. Now, you heard earlier that patients often go away feeling quite lost and unsupported, and they don't know who to turn to. And I've been guilty of this in my career as well, of not signposting patients to charities like Waldenstrom's UK, and also the importance of gaining more data on this sort of area. So we have this Rory Morrison's registry. You may have heard of Rory Morrison Registry, you may have put patients into it. Rory Morrison was a BBC newsreader who died of Waldenstrom's a few years ago. And he wanted a registry to be developed to gain more information. So we really thought part of our active monitoring should include adding patients to this registry to gain more information about the disease. And the final sort of three things was to develop a really easy to read, plain language statement for what Waldenstrom's is, what active monitoring is, that patients could go away and have at home. And then a couple of extra things which are sort of very desirable, in that it really should be managed by an MDT with a considerable experience, or as much experience as possible with managing Waldenstrom's. Not always the case, and not every hospital has that, but it was something that we thought was important, and where it's not possible, that you can approach a specialist somewhere else. And then finally, the development of some educational materials and a digital platform maybe to include multimedia, and that's what Roger has been developing, as well as Waldenstrom's UK and with the support of BeiGene. So those were the recommendations. Now, before we go on to the resources, because the resources we hope you might find really useful for your patients. This manuscript has been submitted, and the first sort of amount of feedback we had was, well, that's all obvious. Everybody should be doing that. We all know we should be doing that. And what we're now turning around to them is saying, well, if it's so obvious, why isn't it being? Why are Waldenstrom's UK getting so many calls from patients? So I think it might not be as obvious as everybody thinks in terms of what active monitoring should be. And what we're going away now to do is to develop some more objective data from patients on exactly what their experience is across UK, what variance occurs, where variance occurs, in order to try to level up the experience that patients have, and then that will feed into this manuscript again, make it a stronger piece of work, we hope. So that's the basics of it, Roger. I'll hand back to you.
Thanks a lot, Dave. So I'm going to pass over to Alison now, who's going to take us quickly through some resources that are available to patients. And on this card, you will see the QR code for each of these. So, Alison.
Yeah, so obviously on all your chairs, we've put a copy of the active monitoring checklist there. And we really wanted this to be a really interactive document. So patients can utilise it, healthcare professionals can utilise it, nurses, clinicians. And basically it's to help structure those conversations, to be able to make sure that the most important topics are being covered in every appointment, and to try and standardise that care throughout the UK so that every patient feels that bit better supported. So we have that on our website alongside other bits and pieces, but obviously there's one there for you to take home, and you can get in touch with us to ask for more. On our website as well, we've got lots of patient-focused resources. So as Angie's video was played before, we've got that in full length alongside another patient's experience, which I think is really good and quite hard-hitting about their experience, and really kind of encapsulates the different thoughts and emotions that we've heard from many different people. And I think they're really good to watch and signpost what other patients do, because we've had a lot of feedback so far that says, it's really nice to hear other people speak of a similar experience of me. And then obviously, like we've mentioned, one of the biggest issues is about educating healthcare professionals. We understand how pressurised the NHS is at the moment. We understand how little time people have. So therefore, there needs to be better education for healthcare professionals as well, to be able to make them feel more comfortable in these conversations, to be able to equip them with the materials that they need. So we've been working on some educational videos that one which is directed at clinicians. So that is depicting a clinician consultation between a patient and sort of explores the language and the information that should be discussed. And there's also one that is specific for CNSs. And that's looking at and that's with Charlotte and myself, and that's basically, Charlotte doing a consultation, talking about the resources that she'd incorporate in her consultations, but then at the end doing a reflective practice. So we want to encourage other nurses to be able to see how that, compares to their current practice, what they could improve, what they, might be able to change, and, do a bit of reflective practice around it. And what we've done is we've hosted it online on this platform called Multimed, which is a really exciting new online platform, and I know they've got a stand here today, and I think there's some leaflets handed out at the end, but so it's all hosted on there, and you can go there and basically it can all go towards your CPD learning, it can go towards your learning log, so when you have to revalidate and different things like that, it all goes to that, because we wanted to make it as engaging and as useful as possible. So yes, on your seats you've got the active management checklist, the BeiGene leaflet there, which will take you straight to our resources on our website, and then obviously Multimed are here to help you sign up to their platform to reach the sort of CPT accredited resources.
So I'd probably just say, looking from the sort of clinician's point of view, these resources are really useful, and the most important thing really is they're made because of patient views. So it's not sort of what we think people will want, it's what people are telling us they want. And the checklist especially is great in practice, because it does give you that backbone of the conversation that you should be having for active monitoring. We all get sort of taken down little rabbit warrens, when we're distracted talking about things. So it's really good to be able to bring it back and sort of cover the main structure. So that's really good. But my most important thing I just wanted to say was that really Waldenstrom's is a rare cancer, and they do get lost in clinics. Some of them are in myeloma clinics, some of them are in lymphoma clinics. But the most important thing is, as a nurse, really, is to signpost them to WMUK. All this stuff will be given to them, or that they'll know about it once we just make that initial flag. So that's one of the most important things I wanted to say today.
Okay, I think we've got our final question, and this is: are there any barriers that would prevent you from adopting these recommendations in your clinical practice? So again, the code number is up at the top there again. We'll just see what comes out from this. Yeah, I guess somewhat predictably, time is always a significant constraint. Mm-hmm. And patients are in the waiting area for 2 hours, and they're in the consulting room for 2 minutes.
I mean, the time thing is an issue, isn't it? But I think sometimes a structure like this can help to save time and focus the mind a bit, our mind as well as so. It might be that it works both ways on that one. Yeah.
Sorry, can I just jump in there as well? I think in terms of the time constraints, I'm from the NHS myself. I left only a year and a half ago, and you don't have a lot of time, and I just think it's times like this where charities really need to step up and show the support that we can give. So yes, you haven't got a lot of time, but it's about understanding who you can signpost your patients to, which is us. Like Charlotte said, we've got these resources, we've got a support line, we've got other patients that can provide that support and information. So if you are tight on time, absolutely please use the active monitoring checklist, but also just signpost patients to us, because we can help you in that way. We can take that burden so that you can do all the clinical bits, and we can do that sort of support that you might not have all the time to do in your clinic space.
And I just wonder, just thinking about this, if this is something that could be almost pre-filled in a future version, which is something that you can look at as well as you look at your blood tests and everything before you see the patient, you know, just to sort of give you what they're really concerned about. It cuts down some of that time wasted maybe as well.
Roger, I was just going to say, this is a really interesting one. The NHS systems are moving towards patient-initiated follow-up and really how we fit this into that. But I think we definitely can fit it in, because it's part of that initial education. So people really know the symptoms that they do need to contact us about. So that's really interesting. And I'm sure all those routine face-to-face clinics are going to be a thing of the past soon.
Yeah, I think that's something maybe we can come around to in wrapping up. But clearly, I think there are emerging consistent. Sorry.
Yeah, no, could I just add to that? In that, you know, part of running a charity or patient organisation is effectively problem solving, and this was one problem that needed to be looked at. But we do that very much with the external environment in mind, you know, realising the dynamics of healthcare, the digitalisation, the extra sort of focus that is put on the patient to lead sometimes those conversations, to come with tools, to try and design things that, I know you're all so busy, you're so overworked, the external pressures, like, you know, don't give me another piece of paper, but actually can we design something that's really quick, that's really easy, that actually helps you? So our job is about finding solutions that work predominantly for patients, but obviously in partnership with their healthcare team, that results in a much better process for everybody and better outcomes for everyone. So, you know, everything that we do, and this is one example of it, is very much looking at all those external factors when we design the solution. And I think, you know, I'm glad that someone's raised that, because what we're trying to do is equip our patients to navigate through an increasingly virtual and digital world.
So we've just got a few minutes to wrap up, and I thought I might come to you first, Davey. What have you taken away personally from this piece of work? Well, is there stuff you do differently now on the basis of this?
Yeah, I definitely think so. I think the thing I took away from it really was that I thought I was doing everything. Yeah, I think I had a little bit of sense of complacency, that I thought I don't need to. I know that I'm, you know, I feel like I'm giving a good monitoring service, but it's clear that we don't always, what we think we're doing is not necessarily always what patients are experiencing. So it's a little bit about having some, you know, humility and listening to maybe I could do this better, and maybe we could be doing this better for patients. So that for me is the thing that I think I've taken away mostly. Yeah.
And I got maybe go over to Charlotte here. What do you think are the take-home key messages for your CNS colleagues?
So I would say that active monitoring is something as CNSs that we should embrace. It's sort of all the core things about nursing, health promotion, looking after the whole. So active monitoring is really a place where CNSs will and can excel. So yes, and also just signposting to WMUK as well. That's my last.
And Alison, what are the next steps, and where do we go from here?
Big question, that. So I think obviously we want to try and get this embedded in practice. We want to try and get patients utilising it more. We want to see, you know, if it works, if it doesn't. Ultimately, what we want to do is we want to start seeing an improved service to our patients and better patient outcomes. And also, you know, we want to see more engagement with other healthcare professionals to make sure that, you know, we're all working towards that same goal, and that is, you know, patients living with WM have better quality lives, essentially.
As CEO of the organisation, Jane, what's your? You've kind of alluded to this a little bit. What's your kind of grand vision for this going forward?
Well, I mean, a big goal for us is to get a standard care pathway for WM. I appreciate, look, you know, wards and storms is a tiny part of your world. You won't see many patients with it, some more than others. And this whole piece and everything we're doing is not about saying people are doing it wrong or doing it badly. It's just to say we recognise there's a tiny bit of your headspace, there's a lot going on. Let us give us some stuff that will help you and help that experience of managing those patients so that they have better patient care and outcomes. And I think just touching on this, what we'd really like to do ideally is do a pilot study with it, test the impact of it, measure that, have evidence, roll it out, and to us that is the first step in achieving a standard care pathway.
Okay, so I think we're bang on time, so I'm just going to wrap up. Just like to signpost people to the multi-med platform where a lot of these videos will be held. Unfortunately, you'll have to watch me, but you may get a good laugh from doing so. But I think they are a good resource. So I'd like to thank everybody who's been involved with this. This is not just about a symposium. This is a body of work that's been going on for a prolonged period of time. It's an excellent collaboration between clinicians, both medical and nursing, patient advocacy in the form of WMUK, but also with collaboration with BeiGene, and particularly Nisa Khan, who has been the real driving force behind this and has allowed this project to happen and to flourish and be successful. So hopefully we can push on from here and maybe have some more to report this time next year, maybe. So thank you all for your attention, and we'll close there. Thank you.